This will be part 3 of the Neurolocalization lecture series, and we'll cover gait and posture when it comes to the neurologic exam. I like to break it up into 2 parts. There are the things that can be observed and things that need hands on the patient, such as proprioception, cranial nerves, and segmental spinal cord reflexes. Observation includes behavior, mentation, gait, posture, and sometimes the paroxysms or spontaneous movements discussed in the previous lecture. Continuing with observation, we will now discuss gait as it relates to neurologic disease. A commonly used term is ataxia, which simply means without order. Please understand that a patient needs to be ambulatory in order to have ataxia, as it means a gait without order. Paresis is difficulty initiating a movement and is often used synonymously with weakness. Although there is truly a difference between the two, from a clinical standpoint, at this stage they can be used interchangeably. Paralysis or plegia is the absence of any movement, which can sometimes sound similar to paresis, but please understand the difference between these terms, and it is hugely important. When describing if a patient has ataxia, again they need to be ambulatory, which means they are able to take 10 unassisted steps. Newer literature recommends changing this definition to 50 unassisted steps, however. From a clinical standpoint, we generally use 10 as a baseline. More terminology to be familiar with is tetra or quadra, which means all limbs, para, which means 2, and generally implies the pelvic limbs unless stated otherwise. Hemi means half and implies one side of the body, and mono implies one limb being affected. With ataxia, there are 3 types to be familiar with. The most common is proprioceptive ataxia, sometimes referred to as spinal or sensory ataxia. However, proprioceptive ataxia is most commonly used. With this type of ataxia, patients will cross their limbs over each other and often scuff their nails and knuckle over on their toes as well. Because spinal cord disease or myelopathies are so common in dogs, there is generally paresis associated with proprioceptive ataxia. The second most common type of ataxia is vestibular ataxia. Since vestibular disease is generally lateralized, patients will drift towards the side of the lesion with vestibular ataxia, often trying to lean against the wall as they walk. There are usually other signs of vestibular dysfunction with vestibular ataxia, such as a head tilt and pathologic nystagmus. The final type of ataxia is cerebellar ataxia, mostly described as a hypermetric gait where there is overflexion and overextension of the affected limbs. Depending on the location of the lesion, it is not uncommon for an animal to have more than one type of ataxia. An example of this would be a patient with a cerebellar lesion, as this could result in both hypermetria and vestibular ataxia. Briefly, it is worth mentioning lameness. Understand that when a patient presents with a gait abnormality, the first step is trying to differentiate a lameness from ataxia, as this will dramatically change your differentials and recommendations. As a general rule, orthopedic disease is more common than neurologic disease and results in a regularly irregular gait. Neurologic disease results in ataxia and an irregularly irregular gait. Sometimes observation alone is not sufficient to differentiate if a patient has lameness or ataxia, which is why the remainder of the exam is so vital, especially when signs are subtle or not straightforward. To help improve confidence in our observation skills, we will observe several videos of abnormal gaits. This is a middle-aged French bulldog, and right away you should be able to appreciate that the pelvic limbs are abnormal. The patient is scuffing the toes and crossing over. This is a classic example of a patient with proprioceptive ataxia in the pelvic limbs. Just based on this gait alone, we should be most suspicious of AT3, L3 myelopathy. However, we would want to perform segmental spinal cord reflexes to be certain. Here we have another patient with an abnormal gait, but this gait is very predictable in its abnormality and is an example of a right thoracic limb lameness. Notice the stark difference between this patient and the previous, as this patient's gait is very erratic and not predictable. This is an example of vestibular ataxia, and the patient is drifting towards the left. However, just based on this video alone, we cannot differentiate central from peripheral vestibular disease. This is a less common type of ataxia that we see. Hopefully you can appreciate that all the limbs are affected and can be described as having high stepping movements or overflexion and extension of the limbs. There is also a truncal sway that is appreciated when the animal is standing and is moving side to side. This is a patient with cerebellar ataxia. This is a shorter video, so replay it if needed, but the key takeaway here is that thoracic limb stride length is shorter than the pelvic limbs, what is often referred to as a two-engine gait. This is a patient that would localize as AC6, T2 myelopathy. We have another patient with our most common form of pelvic limb dysfunction, where there is marked paraparesis. However, this patient is not able to ambulate without assistance, so would be described as non-ambulatory paraparetic, but the label of proprioceptive ataxia is inappropriate as a patient must be ambulatory to have ataxia. In this patient, we cannot tell if it is T3, L3 versus L4, L3, and again, we would need our reflexes to differentiate between the two. Next, we have a patient with no movement appreciated in the pelvic limbs. Therefore, we would say this patient is paraplegic. However, the description of non-ambulatory is redundant and not needed in a paralyzed patient. Reflexes would again be needed to differentiate upper from lower motor neuron. Finally, we have an animal with little to no movement in any of the limbs. So this could potentially be either a cervical myelopathy or motor unit disease, and this patient actually had a tick present, which was removed and the dog was walking a day later. To summarize, when a patient presents with a gait abnormality, we are generally trying to decide if it is orthopedic or neurologic. If it is neurologic, what kind of ataxia is present and which limbs are affected. If it is just the pelvic limbs, we can just say para. And if it is all the limbs, then we say tetra, being certain to perform spinal cord reflexes, as it helps us determine cervical myelopathy from diffuse motor unit disease. The last part of this lecture will run through different postures, some of which are extremely helpful with neurolocalization and others help complete the picture. Let us start with two classic neurologic postures. On the left image is a dog that has extensor rigidity in all the limbs and a star-gazing appearance, better known as opisthotonous. This is a decerebrate posture and indicates a brainstem lesion. The patient on the right has a similar posture, but the key difference is the pelvic limbs are flexed. This is known as a decerebellate posture and is indicative of a cerebellar localization. At first glance, the posture might look similar, but hopefully you are able to appreciate the difference with a more thorough evaluation. Other postures to be familiar with are head turn versus head tilt. The drawing on the left is an aerial view of a dog, so we can observe the longitudinal axis. If the head deviates one way or another in relation to the longitudinal axis, this is referred to as a head turn. The image on the right is a drawing along the horizontal axis. If the eyes are no longer in line along the horizontal axis, this is referred to as a head tilt. Torticollis is another term to be familiar with, as it could look similar to a head tilt but is indicative of a cervical lesion, often related to a congenital abnormality. A more common posture you will come across clinically is a Schiff-Sherrington posture. This is when the thoracic limbs have increased tone, and the pelvic limbs are often paralyzed, and is most commonly secondary to a T3, L3 lesion. To differentiate this posture from a cervical myelopathy, it is important to get the patient upright if it is safe to, and assess proprioception and motor function of the thoracic limbs. If they are normal, but the pelvic limbs are severely paretic to plegic, this indicate a Schiff-Sherrington posture and likely a T3, L3 myelopathy, although L4, L6 lesions are reported to cause this as well. Another classic neurologic posture is the sardonic grin, or more properly called rhizus sardonicus, which this patient is presenting with. Notice how the ears are pulled back, along with the muscles of facial expression, giving the appearance of a strabismus in the eyes. Although this posture is not specific to a neurologic abnormality, it is most common with neurologic disease, and that is a neck-guarded posture. Notice how the dog does not want to look up or around with their head, but rather only does so with the eyes. Other causes for this could include a soft tissue injury to the neck or a polyarthritis. Similar to the neck-guarded is the kyphotic posture, where the middle part of the back is arched. Although this could indicate thoracolumbar hyperpathia from a neurologic disease, it could also be the result of weight shifting from the pelvic limbs to the thoracic limbs from pelvic limb pain, such as with bilateral cranial cruciate tears, or abdominal pain such as with pancreatitis. This concludes the lecture on gait and posture and is the final part of the observation for the neurologic exam. If you are recording a neurologic exam, hopefully this gives you an idea how helpful the observation part of the neurologic exam is. Knowing that certain behavior changes alone can localize to the forebrain, or that mentation changes could localize to the brainstem is extremely helpful because sometimes that is the only abnormality. This concept applies for gait as well. Could it be ataxia or lameness? Then further knowing if the patient is ambulatory or not, or even has motor could help with prognosis and recommendations. Finally, understanding that certain gaits localize to certain areas is also a key concept to grasp with neurolocalization. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.